allergy family and have been a part of the FAIR family from the start. Along with the other co-chairs for this event, we're thrilled to welcome you here today, and thank you for joining us. This is an issue that binds us together. You are not alone.
Family is love and support you can count on forever.
Family is
unconditional love.
Family shapes who I am and drives the work that I do.
Family is the people I care the most about and will do anything to support.
Thank you all for joining us. This is an extraordinary time, and we want to continue to support our FAIR family, now during Food Allergy Awareness Week and always. I'll hand it over to Lisa Gable, FAIR CEO, to start today's programming.
Hello and welcome to FAIR's first ever virtual symposium. While the circumstances that brought us here today may not be what any of us could have imagined, we are so excited to have you with us as FAIR charges forward into the digital frontier. The food allergy community is one of the strongest I've come to know. Our families, our patients, they face challenges every day, but especially during this unusual moment of a pandemic. And as you saw and heard earlier, family is at the heart of what brings us together, especially today. FAIR is so proud to be able to continue to support our community, our family, providing value and touching all aspects of life with food allergy. From stages of life resources and webinars to leading edge research, we are thrilled to support food allergy patients across the country. Today, we will focus on helping our community respond to the difficult circumstances in which we all find ourselves. We'll explore how to manage anaphylaxis during a pandemic, how to access safe foods when the shelves are bare, and we'll examine COVID-19's impact on clinical practice and drug development. But first, I'd like to thank our wonderful co-chairs who made all this possible. Denise and Dave Bunning, Un Lee and Robert Criswell, Talia and Andrew Day, Louise Matthews and Tom Flickinger, Antoinette and Michael Griffith, Kim and Alan Hartman, Helen and David Jaffe, Rebecca and Sasha Lanovic, Wendy Fox Lawson and Jim Lawson, Kari and Michael Sachs, Karen and Dean Taglia. And with that, I also look forward to introducing you to our distinguished guest, Dr. Giselle Moznayan, Dr. Anya Nowak, and Dr. Corinna Wittner. But it's my greatest pleasure to introduce you to Tom Casali, FAIR's Chief Medical Advisor. Tom, take it away.
Thank you, Lisa. It's my pleasure today to introduce our three panelists. We have a very distinguished and accomplished group of individuals that have really done a tremendous amount of work in the food allergy field. So we've received a number of very good questions from all of you across the country about dealing with food allergy during this unsettling time of COVID-19 pandemic. And I want to start with Anya first, because Anya, you've sort of been at the epicenter of this pandemic living in New York City. Anya is a professor of pediatrics and director of the allergy program at NYU. So one of the things that have come to light is fear, I think, by some patients about going to the emergency room, because especially in the times when you're in an area where there's a lot of patients with COVID-19, folks just don't want to go in. So my question to you is, what do they do if they have an anaphylactic event? I understand there's some new guidelines out there, and maybe you could enlighten us a little bit about them.
Well, Tom, thank you for this introduction, and thank you for the question. Yes, indeed, I'm located in New York, and as you know, New York has the highest load of COVID-19. And 2 weeks ago, it was really, really scary to even think about going to the hospital. So I just want to backtrack a little bit because I'm a food allergist, and education about recognizing and managing anaphylaxis at home, at school, is really the most important part of our practice, and we reinforce it every time we see our patients. And really, the basis is that once you recognize anaphylaxis, you start treatment. And when you administer epinephrine, we recommend that you activate emergency services and get a follow up in the emergency department, just as an extra security to make sure that you don't need additional treatment, that you don't have late symptoms. And this is under normal circumstances. This is the mantra that we teach our patients to. And obviously, as Lisa said, we're living in unprecedented times. The COVID-19 pandemic really hit us. If somebody told us 2 months ago that this is going to be happening, I would have never accepted this as a reality. But it is a reality, and millions of Americans are at risk at contracting COVID-19. Right now, we have probably 1.4 million documented infections and many fatalities. So, on one hand, we have to consider the um, severity of anaphylaxis and allergic reaction and treatment. On the other hand, we have the risk of infection when you go to the crowded emergency room. And also if you utilize those emergency services, then you also potentially may overburden the already stretched thin healthcare system. So those are the factors that we have to take into consideration right now under those special circumstances. And we with you as the lead author and Julie Wang, we thought that it is really important to sort of provide some commentary to that, and potentially alter the protocol for management of anaphylaxis. And this is all with full disclosure that this has to be it should be discussed individually. And there will be areas of the country that are not that significantly affected by COVID, where the no, just sort of routine anaphylaxis management should be continued. And also, there are patients who have particularly, very severe form of anaphylaxis in the past, who have been intubated, managed in the hospital, or were treated with multiple doses of epinephrine. For those patients, for any kind of anaphylaxis, we would still suggest activating emergency services immediately, because it is more likely that those individuals would require additional treatments. But for other patients who don't have those risk factors, we proposed an altered, a modified protocol, which would emphasize more management at home, with not activating emergency services immediately after utilizing epinephrine, just sort of assessing the response, and trying to determine if the um, intervention in the emergency room is necessary. Um, and you might have seen this emergency plan that we've proposed, which now the indication for use of epinephrine remain the same, and anaphylaxis is an medical emergency. And you obviously, I think the most important message is really, if you think this is anaphylaxis, if you think that this allergic reaction is severe enough, or it's multi-system, even though if there are mild symptoms, you should initiate anaphylaxis management and use your epinephrine. This is really the most basic, the most important message, that you don't want to delay the treatment. And the sooner you use epinephrine at home, the better the outcomes, the lower the risk of having complications, of having more severe symptoms later. This has been shown in multiple epidemiologic studies over the years, and this is really worth emphasizing, that you want to use epinephrine as soon as you recognize anaphylaxis. Where this modified anaphylaxis plan diverges from the routine plan is that after using epinephrine, you don't automatically activate the emergency services, but you do observe and monitor for symptoms. And depending what happens, if the symptoms resolve, then you observe and you would then follow with your normal actions. So you would administer oral antihistamine, which we would suggest using the non-sedating antihistamine. And if you have asthma, you could use your asthma medications, and you definitely notify your physician at a sort of non-emergency basis. And this takes into consideration situation like your physician may be deployed and may not be available, and you can manage this at home with careful observation. It is helpful. Some people already have blood pressure monitoring devices, so monitoring blood pressure in older patients that what baseline is may be helpful. It is important to remember that positioning is after using epinephrine, which you obviously use when you're sitting down, then sort of laying down with your legs elevated to improve the blood return to heart, so to maintain the blood pressure. Being in a position if you're alone, that's really scary. If you're experiencing anaphylaxis and you're alone, you want to be close to the telephone. You want to be in a position you can open the door if you need to open the door for the emergency services, and then you observe. And if your symptoms escalate, you can use epinephrine again in 5 minutes. If symptoms improve after the second dose, then you'll just observe farther. However, if the symptoms don't improve, or if there are residual symptoms, or if you're worried, then we definitely recommend activating emergency services after using the second epinephrine without improvement in symptoms. What is also important, we emphasize in our editorial, is to observe the patient for late symptoms. Biphasic reactions are the reactions that have an early symptoms and late symptoms. And you want to, if you're alone, then you want to sort of be attuned to this possibility that you can have a second wave of symptoms within a couple of hours. And if there are others who are observing you, they should also pay attention, and especially if parents, caregivers taking care of children. So I think this is the, sort of like the gist of it, the general gestalt.
Mhm.
Um, Another thing I would say, and I think it's very important, particularly under pandemic, is that to make sure that your epinephrine devices you have at least two, and they are in good shape. They are non-expired. And you can use them in the case of emergency. And if you experience an emergency and you used your supplies of epinephrine, then you should definitely contact your physician to get a prescription to refill your medication as soon as possible.
Thank you, Anya. That was very good to review the new paradigm for treating anaphylaxis at home, especially if you're in an area where there's a big concern about having exposure to COVID-19. I think one of the other things that we're seeing a lot of and hearing from our patients with food allergies is the difficulty in finding the foods that are allergen free for them. So I wanted to ask Karina Venter, who's Associate Professor of Pediatrics at Children's Hospital in Colorado. If patients are having trouble accessing these foods, what do you sort of recommend? Are there any substitutes or any ways that they can get around this problem?
Yes, there are ways to get around it. It doesn't take away that it has been more difficult for the food allergy sufferers that we work with finding their safe foods. And I think, irrespective of COVID-19 or no COVID-19, it's very important that people with food allergies should know how to read a label. And I mentioned it yesterday as well, is that we know that there may be some issues about food labeling as well, but this is the best we have and the safest approach we have at the moment to make sure that we don't have accidental exposure to the allergen. And so there's really good information on FAIR website, www.foodallergy.org. about reading food labels and how to avoid the top 8 allergens, which hopefully we'll have top 9 not too long from now. Um, what I always say to people with the common food allergies is the good news is that FELCPA cover the top 8 allergens, which are milk, egg, fish, crustacean, shellfish, tree nuts, peanuts, wheat, and soybeans. And these foods or foods containing these allergens have to identify the allergen clearly on the food label, either in bold or parentheses, or quite often it's in bold and in parentheses. They can then also indicate that the product contained the allergen in the allergen box. If both are available, it's important to always read both the ingredient list as well as the allergen advice or the allergen box. But products do not have to have an allergen box. So if it's not on the product, it doesn't mean that there's no allergens in it. It's always important to look for the ingredient list. The other important thing to realize in the United States is that the front of pack is not covered by FELCPA. So a product may say no milk containing products, but then when you look at the ingredient list, casein, which is a milk protein, would be one of the first ingredients, or it could say vegan, but it may still have detectable trace amounts of milk available. So again, don't just look at the front of pack, always go back to the ingredient list. And if there is an allergy advice box or allergy advice information, read that as well as. But I always think, when you really live in a situation where you don't want to have any accidental exposure, and Dr. Novak Vexren beautifully explained the complexities at the moment of having anaphylaxis and then having to make all these decisions about treatment, going to the hospital or not. The best way to avoid that from happening is to really just stick to single ingredient foods. Like, for example, buying just fruit. And at the moment, tangerines are available. Apples last a long time in a fridge. So apple may be a better idea than an apple pie, where you try and decipher whether the apple pie is indeed wheat-free or whether there's no milk available. I think also trying to start cooking so that you exactly know which ingredients and which single and simple ingredients was used in a product also help to make sure our food allergy sufferers are safer. I most definitely have been working with a number of mothers, either by email or telephone or telemedicine, where they are really, really anxious about severe reactions in the children. And we have really gone and changed. We've individualized the children's weekly and daily menus to make a use of single ingredient foods as much as possible to minimize the risk of accidental ingestion of the allergen.
Thank you. Very good advice. I ask either one of you, with the problems of finding some of these foods, have you seen an increase or heard of an increase in the number of food allergy problems?
No, I was just going to ask, ask you and Karina if you had more, calls or reports. Actually, I would say it's probably less. I mean, I'm thinking, people are not eating out. Children are not going to school. They're a more controlled situation with all of the caveats of limited food supply and the limited choices. I in my I have no way of really sort of knowing whether this is true for everybody, but in my practice, I think I would see fewer accidental reactions right now when children are sort of locked at home, and parents are really controlling everything that goes into their mouth. But I totally agree with Karina. Just prevention is the best is the best treatment of anaphylaxis possible. Don't get to the point that you are having reactions.
Yeah, I
But
must say,
it's hard. I mean, like in New York, Karina, I'm sorry, it's impossible. My husband goes shopping for the entire family, right? Like once a week. And he says, like there are things that are not there anymore. Like you cannot, I don't think I've seen chicken in the store, or, or some meats, or, it's really um
I
difficult.
definitely have that, again, diet diversity is my interest field. So when I advise my patients, I talk about diversity of fruit and vegetables, using different grains, So I've been inundated with emails. I cannot find quinoa anywhere, or there's just no millet
Yeah.
available. And so, but it's like I say to the moms, it's fine. If we can't buy wheat-free flours, then let's just eat potato. Or if we're just going to have rice and potato for the next 4 weeks, that's perfectly okay too. I've had lots of emails from mothers. Again, we're trying not to focus on FPIEs today, but particularly my FPIEs families, they trust their brand names. This is the wheat-free flour they use. This is the milk alternative they use. And that particular brand name is just not available. And they're just not happy to change from one almond beverage to another almond beverage. So I've spent a lot of time, trying to substitute and, calling companies, which is the other problem I didn't highlight. Normally, if you call a company or a manufacturer to try and find out exactly what the ingredients are, what are the risk of cross-contamination, you may spend half an hour waiting until you finally speak to somebody. At the moment, I could wait 2 hours waiting to get the information, which is, again, quite a burden on the family. So definitely not heard of more reactions, but definitely heard on a daily basis
Yeah.
of people that can just not buy the products that they use
Right.
and they trust. And so I've spent a lot of time having to come up with alternatives. Talk about my husband literally sending him to the shop and say, can you go and see if you can buy this, and this? Because I try and stay away from the supermarkets if I can, but it's not been easy for patients. Definitely not.
Thanks.
But I have another sort of comment is that the questions that I've been getting more is like really, is this anaphylaxis or, especially right now with the reports of this pediatric inflammatory syndrome, like
Right.
parents are worried, how do I know that versus, is this a inflammatory syndrome or is this anaphylaxis? And I think fever is really high fever, consistent high fever is really the most important distinguishing feature, because otherwise, some other symptoms may be, similar, and you definitely could confuse those two. But the fever and the just overall very ill appearance of the child that is progressively getting worse is important to emphasize.
So Anya, when everything was really ramped up in New York with all these cases, there was a fear of going to the emergency room. Has that been reduced now? And what types of precautions have been implemented in hospitals to keep someone without COVID-19 that has to go to the emergency room safe?
Well, obviously 2 weeks ago and now it's a totally different situation. Like the caseload has decreased dramatically, and if you need to go to the hospital, you should go to the hospital. If you have asthma attack or you need help, otherwise, you do have to utilize those services. So the hospitals are very cognizant of those risks. And obviously there's the physical distancing, trying to spread the patients, opening additional space that is available as a waiting room, isolating patients with suspected symptoms, checking temperature on arrival, inquiring about the symptoms, and then sort of streamlining those patients into the different areas, and disinfecting and cleaning and, changing protective gear from, moving from patient to patient, isolating more those patients that would be at risk sort of to be a source of a high load of a virus. So for instance, with nebulizers administered in the emergency room, they are administered in separate rooms and really trying to isolate other patients from the potential for inhalation of those of the virus particles that could become airborne during such a treatment. So yes, the hospitals are taking a lot of precautions. So you know, triaging patients, screening them for elevated body temperature for the symptoms, and then sort of trying to separate those that are at higher risk or those who have known exposures, known contacts, and then physically distancing the patients as much as possible and using protective gear and to just stop the spread of the virus and cleaning and disinfecting.
Yeah, I agree. I think that's been the biggest thing that I've noticed also in my area is that uh, the hospitals are doing a really good job at sequestering suspected COVID-19 patients from other patients, and regardless of whether somebody has an acute anaphylactic event from food or they have other symptoms, myocardial infarction or severe asthma or whatever, you need to go to the emergency room under certain circumstances, and you shouldn't hesitate to do that because I think the hospitals are really doing a great job of trying to sequester patients that put you at risk for contracting COVID 19.
Yeah, I totally
Um,
agree. Yeah, you don't want to delay the care, when it's
that's
needed.
right. So, Karina, I think you've already answered this, but I mean, it's obvious from what you've said so far. But tell us again, why do we need a registered dietitian to help us with food allergy? I mean, what?
I think, we had that yesterday on the Twitter discussion as well, which was probably the tweet that I've ever tweeted that got most retweeted. And it's about the individual approach that dietitians have. And we also have the time. I have no doubt that allergists like Anya have got just as much knowledge as we do, but she just doesn't have an hour, even 2 hours to sit with families and talk them through all the complexities of managing food allergies, particularly if we're dealing with multiple food allergies. So I think we can individualize the approach. We understand what baked milk and baked egg mean. We offline discuss till ad nauseum, really, whether something is a baked milk or a baked egg containing product. We can give families culturally appropriate substitutes of something that's equivalent to baked milk or baked egg. Um, we can look at what a child is currently eating and we can actually change that by choosing very similar products that may just be free from the particular allergen or allergens. And then I think the main thing is, we keep an eye on the height and the weight and the growth. We know that children with food allergies tend to falter in terms of height growth before they falter in terms of weight growth. So we can keep an eye on that and we can make sure that the diet is nutritionally sound. So again, as a dietitian, I think people should eat and they shouldn't over rely on supplements. But during this COVID period, I've just had a number of cases where because of financial reasons and availability of food, we got so restricted with the variety of foods in the diet that despite the fact that I give them all the protein and calories they need, we did have to revert to a supplement which we may use just on the short term to provide sufficient calcium and iron. And I think that's very reassuring for families to know that, yes, perhaps we can't buy the most expensive milk alternative beverage on the market that's fortified with calcium, vitamin D, and iodine, but we will go for a more affordable alternative and we will top up or supplement the diet with the nutrients that we need. So, I think we are very practical dietitians. We want people to eat. We want to keep the message simple and we want to tell them what they can eat alongside what they should be avoiding.
Anya, I want to go back to something about the management of anaphylaxis. I know in the algorithm, you talk about the importance of monitoring for biphasic reaction, and that sometimes 2, 4, 6, 8, or even longer hours after the initial reaction, you could have a recurrence. What what are the types of things patients should look out for? Do they get the same types of symptoms? Do you use epinephrine again? Is that the time to activate the emergency medical services, or do you sort of do what you did with the initial reaction?
Well, so that's a great question, Tom. It essentially could be anything. The second phase of anaphylaxis would be as severe as the initial one, or could be less severe. So it really depends of what kind of symptoms you are observing for the same symptoms as initial reaction, and depending on the severity of the symptoms, how potentially dangerous they are, you will treat as the initial symptom with epinephrine. Regarding the activation of the emergency system, I would follow the same recommendation for the initial reaction. Another point that I would like to make is that, I mean, we're here, as Giselle said, we're available via telemedicine. And if you have any questions, if you want to sort of proactively discuss, go over this management plan and see whether this modified management plan is the right thing for you to do. Uh, by all means, please do. This is the best thing you can do, to be prepared, to be aware, to really feel good about it, and be confident that you can manage that reaction. But um, and also, as we mentioned before, after sort of depending on the timing, when is this original symptom, the symptoms of the original reactions, when they have started, you may have time to contact your physician in between to sort of go over the reaction on a non-urgent basis. But biphasic reactions really can happen within 2, 4, sometimes even up to 24 hours in rare instances. But it's good to be aware of it, good to be on the lookout, and definitely have a supply of medications that are, available. And that sort of brings another point. If you have used up your supply of epinephrine, and then the symptoms again are consistent with anaphylaxis, and of course, obviously, you are going to call, you will activate emergency services if you don't have appropriate medications for managing anaphylaxis at home.
So basically, if somebody has a reaction and you successfully treat it at home and you're out of epinephrine, then it would be good to send a family member to the pharmacy to
Right.
pick
Yeah.
up.
Well, absolutely. You want to get it,
Yeah, so you do it.
That's a good point. Thank you.
Okay. Karina, I wanted to go back to that question I had asked you. So what is the typical food allergy person living in someplace and not affiliated with a physician at a university that might have a tie-in with a registered dietitian? How do they get advice from a dietitian? What do you advise them?
I think that's a big problem. As you very well know, we need to train dietitians in the US at mass to deal with food allergies, um, because I think it's a crucial part of the allergy team. But there is frustration from allergists, I'd say, all over the country when I give lectures about how to get access to an allergy specialist dietitian. Having said that, I think, the patient support groups are doing amazing work in trying to educate people, having information available on their websites. I actually have a list of bloggers who I trust and who I know what their knowledge base is like. And I recommend my own patients to go there. If I get emailed by somebody out of state, we have the International Network of Diet and Nutrition in Allergy. We email the group and ask if they know of anybody within the state, even if it's still a 2-3 hour drive, that could help somebody. So some people, yes, definitely, they just never see a dietitian. But we do try to get access to allergy specialist dietitians. Anya has been involved with a number of the projects that we're working on through the American Academy of Asthma, Allergy, and Immunology, where we've now got education series on cow smoke allergy. We've written a paper with really useful handouts on eosinophilic esophagitis and the dietary management of eosinophilic esophagitis. We've got the international FPIES guidelines with very helpful information on how to wean a child or how to introduce foods in an infant with FPIES. So we're definitely trying to extend the number of allergy specialist dietitians in the country to give as much information and help as possible. But they are definitely a group of patients, unfortunately, that just have to find the information for themselves, or contact patient support groups.
Thanks. Well, before I go back to Anya, I wanted to ask you to give me some cooking tips, because you said you're giving cooking tips. So what kind of cooking tips do you give people?
Well, specifically now in the COVID times, there's sort of like the one side of the coin where people think everybody has a lot more time to cook. Then there's the other side of the coin where there's limited availability of ingredients. And so, we use a lot of batch cooking advice. I think the most magical utensil in a kitchen is really a muffin or a cupcake tin, because you can portion things out, you can freeze them in small portions. So again, cooking tips, I'd say try and find easy recipes, 3 to 4 ingredients, something you can portion out in a muffin or a cupcake tin, and something that freezes well. And do not forget to label it well. You want to put on what's in the plastic wrapper or in the plastic container, what's in it, what the ingredients are, and also the date. Because I have baked zucchini muffins on occasion, and then, a month later, nobody can figure out what is
No one
in the
else
freezer.
wants it.
So
Right.
that's perhaps another important tip. And, again, we don't want people to end up with food poisoning. So a date is important. And, if my children have a number of friends with different food allergies, and I always think I'll remember what I put in the particular muffin or cupcake or lasagna. But then when I thaw it, I can't remember. So important to put all the ingredients on, so that whenever somebody do come and visit with a food allergy, you know very clearly what you've put in that particular product. But keep
Tom,
it simple. More than 5 ingredients, I think, is just too complex.
Oh, wow. So I would never pass this test because I like to throw in a lot of things. All right. Anya, are there any shortages of medications used to treat anaphylaxis now, like epinephrine, or should patients be concerned?
I'm not aware of it. I did look it up, and obviously, um, this is an important topic, but I did not find any information about shortages. So I think we're good with epinephrine, with antihistamines, and I just want to emphasize that we do prefer non-sedating antihistamines such as cetirizine for managing anaphylaxis, just to avoid the sedation, being drowsy and unable to sort of evaluate if this is a part of the drug or if it's a part of the reaction. Um, there has been some reports about potential shortages of inhaled medications for asthma. So some of the patients that have asthma, because asthma medications have been used, bronchodilators have been used for treatment of COVID symptoms, the cough and shortness of breath. So here, there's some concerns, but I think it sort of depends on where you are. And again, I have not had any reports from the patients here that are unable to get asthma medications. But in general, there is this awareness that you should try to be more cognizant about prescribing, large number of inhalers. Just try to preserve the medications for those who need them the most.
And you had mentioned a potential risk, and that is the use of nebulizers because of the aerosolization. Now, most people do not have to be treated with the nebulizer, right? So, what are you telling your patients with asthma now? Anything different? Not to use a nebulizer, to use a spacer instead, or what would you advise?
Well, I would say that if possible, right, use the inhaler, the meter dose inhaler, HFA inhaler with the spacer. And like you can use it for children, for infants, for older people. If a nebulizer is the only available option, and the patient needs it, and some people report that they respond better to nebulization versus the inhaler, then of course they should use it for acute asthma exacerbation. But then they should take precautions, being aware that the virus may remain airborne for about 2 hours after administration of the treatment. So It really depends on your setup. If you have a house and you can go out and you can administer this treatment somewhere outdoors, where it's not going to be spreading the virus inside the house. Potentially, if you are sick, if you're infected, that's ideal. Or do it in some room that it's not sort of being accessed by other members of the family. Otherwise, if you live in an apartment in Brooklyn, this advice is not going to be helpful, but you know do it in the area of the house or in the room that can be closed, and then avoid going in there for a couple of hours, if possible. Otherwise, use gloves, use the and use masks that pretty much everybody now is used to wearing, unfortunately.
Yeah. And I think sometimes we forget about the utility of epinephrine to treat an acute asthma exacerbation.
Well,
So if patients are having a hard time and they're not able to use their inhaler, epinephrine is a great drug to use for an exacerbation to dilate the airways, reduce the edema, etc.
well, that's my spiel, Tom. You're stealing me because for me, no, actually, it's not right. You're reminding me because this is my talk, right? Like, epinephrine has been used to treat asthma exacerbation. This is a safe drug. Before we had inhalers, it works wonderful for the airways, and it's very safe because some people have misconception about using epinephrine. They're worried, if I use epinephrine, I have to go to the emergency room, and that's not true. You're going to the emergency room because we worry, about the allergic reaction, not because the potential side effects of epinephrine. It's a super safe drug. It's really, there's no relative contraindication to using epinephrine, especially in the case of an allergic reaction or, in case of bad asthma attack.
Okay, thanks. So, Karina, I want to ask you a question that's been something that a lot of patients are asking now because they're not going to the grocery store, right? Because they don't want to be exposed to COVID-19. So they get a virtual shopper. And your patients are probably very used to reading labels, especially the ones that you've instructed on how to do that, but the virtual shopper is not. So what kind of advice do you give to food allergy patients who are using virtual shoppers?
Well, the first line of advice is simple. Don't ever eat anything unless you've checked the label yourself. I think that way you rule out any possible mistake that the virtual shopper could make. I think in terms of a virtual shopper, I must say that's something that I haven't actually used, or my patients haven't asked me about. If it's a person you're referring to, you're going to have
Yep.
to teach the person how to read a food label. Definitely written advice. We talked about the issue of translations yesterday, that sometimes we give somebody a Spanish sheet on how to avoid milk, but they're actually buying products with English labels on. So make sure that the person knows which English or American words they have to look out for on a label. And then I would say the second layer of advice is, so first, make sure they can read the label. Second, I would give them a list of known safe foods that you normally eat, hoping that they may find that particular brand. You may want to do your own homework. This is what I advise my patients when they shop online, is to, if they can't find the product that they normally buy, is look for alternative options online, check the label yourself. So they can give names of alternative products that the person can look out for. But then eventually, if it ends up at home, before you eat it, you have to check the label. And then definitely, if this person is buying food for the whole family, so the allergen-free foods, let's say milk-free or peanut-free, as well as food for the rest of the family that may contain peanuts or milk, it's important to also ask the person to pack it separately. So to have certain bags with the allergen-free foods, and then certain bags containing the foods with the allergens in. But definitely, I cannot stress this enough. Whether you order from a restaurant, whether you order your own food online, or whether you use a virtual shopper, Or even if you send me to go and buy your food, don't eat the food unless you've checked the label yourself.
Yeah, that's great advice. I know my wife has been using Instacart, and they're always texting her and saying, "Well, we don't have that. Can we give you this?" And I think a lot of the virtual shoppers aren't used to dealing with people that have food allergies. So I think that caution that they have to take to absolutely not only tell the person that's shopping for you, but double check before you grab something off the shelf.
Yeah. And also, in terms of buying from restaurants, who now deliver at your door, I think is put as many layers of safety into it as you can. Check the ingredients online, then order the product. Put in the comment box, because there's always a comment box where you can say, leave it at the door or I will come out. But in the comment box, list again your allergies, all the possible terms that they need to look out for. Make sure it is not in the food. Ask them to actually put your food in a separate plastic bag or carrier bag. And then I would normally follow up by a phone call to say that I have just ordered this product from you. It has to be peanut free. I've made sure that the ingredients online state there's no peanut in. I've also put the information in the comment box. I just want to double check that you got the information. And then, some restaurants, especially now in this COVID time where everybody's looking for business, would go as far as putting the ingredients of the actual dish on the container so that you can check the ingredients again, when the food arrives. But as many layers as possible to make sure that the food, events are being free from the allergen that you are avoiding.
Thanks. I know another issue that's come up, and a lot of patients have been asking, is whether or not if you have food allergies or asthma, you might be at higher risk for either contracting COVID-19 or having a worse course. And before I pick on Anya to answer that, I just want to remind everybody that we're definitely interested in that question. And in order for us to answer that appropriately, we need people to sign up for our registry to enter their information so that we could really get the best information about that. So just go on to fairregistry.org and enter in your information, and that'll help us dissect that out. But any insights, Anya, as to whether you think food allergy or asthma is a increased risk?
So I think we all were worried, right? Because we were thinking, the COVID attacks the airways and that's how it spreads. But actually, it turns out, I mean, at least with the evidence we have so far, that there is no increased risk of infection or more severe. More severe course, and you know, there are studies that looking at the receptor that is used um, by the virus to enter the cells and to infect the cells. And it's actually this virus is I'm sorry, this receptor, the ACE2 receptor, is decreased in the airways of the patients with asthma. So this would suggest that patients may be at actually lower risk of becoming infected with COVID. As far as other types of allergies, uh, again, we don't have enough information. It doesn't seem like it is a risk. It shouldn't be a risk. And I haven't heard about any, association between this pediatric inflammatory syndrome, which is sort of resembles Kawasaki disease, with allergic conditions. So I would say no. I think it's a bit of a silver lining here that people with allergies are not at increased risk to acquire to contract the disease or have a more severe outcome.
Okay, thanks. So we only have a couple of minutes left, and I just want to ask one more question. We've been focusing a lot on kids, it seems like. Of course, you both work at pediatric units, maybe that's appropriate, but
Yeah.
is there anything unique or different that you advise adults to do that algorithm for anaphylaxis, it's the same for adults as it is for children. And the dietary recommendations, are there anything that you would advise adults that might be different than kids?
So I just want to say that I do now work at a pediatric hospital, but I keep telling the boss that I really need to go to the adult hospital too, because I actually had my training as an adult allergy dietitian. So I always make a point of the fact that I'm not a pediatric dietitian. I am an allergy dietitian who sees children and adults. But there's also so many hours in the day. I think from a dietary advice point of view, for the children, of course, like I said, we focus a lot on the growth, but and on adults, we will look at weight loss. In the majority of cases, when adults do lose weight because they're on an exclusion diet, they normally don't go under a BMI of 21, 22. So we normally don't get too concerned. We have the same issues with micronutrient adequacy. So, we'll be supplementing vitamin D, iron, calcium as we do in the children. We have the same problems with finding suitable replacement foods, although it's slightly easier with the adults because you can have a conversation with the adult and say, either you're going to eat this coconut-based yogurt or you're just not going to eat yogurt, because there's no option in locally available. So there's many different options in most places. So that and then of course the bit about the adult food allergies, which I find fascinating, and I'm just not seeing that much at the moment, is the whole issue of lipid transfer protein allergies, if I'm allowed to call it that, or pollen food syndrome. So it's really dealing with the nut allergies that may be severe, may not be severe, cross-react with certain fruit. And my favorite bit of advice to these adults is to say, if you chop up the fruit enough, you don't have to cook or bake it. Just chop it up or put it through a blender and be able to drink that apple juice, even though biting into an apple is going to give you that severe oral itching. So slight differences, but I'd say for the most of it, we're concerning about similar allergens. The fruit and vegetables and nuts are slightly different in the adults. And then finding replacement foods, because again, there is no paper to quote, but I can tell you from practical experience that food aversion and texture aversion is just as big a problem in our adult food allergics as we are with the children. But, rightly so, all the research was done in kids. And that's perhaps something else that you can ask people when they sign up for your registry is, the adults with food allergies, do they have texture issues? Do they have food aversion issues? And I hope I made the point that adult food allergics are just as important as the children.
Well, thank you. As an internist, I agree. Uh, we're out of time, so I want to thank both of you and Giselle for a wonderful conversation and for sharing all your insights during this unprecedented time of COVID-19. You guys have done a fantastic job, and we really appreciate all you do for our patients with food allergy. Thank you, everyone, for joining us.
Thank you for having us.
Absolutely. Bye.
Bye.